I want to start by, first of all, welcoming Tammy and Kim. Tammy and Kim are two really special leaders, I'd say, who started doing AI before AI was cool with us. So I thought from a standpoint of talking about how we future-proof healthcare, how do you drive change in healthcare with AI, you couldn't get two better leaders who both understand the impact of the technology, the impact on the workforce, how to drive change. And maybe to start, like, I feel like right now in particular, we are at such an inflection point in healthcare with even more regulatory changes, more Medicaid cuts, more reimbursement pressures, continued staffing challenges that we've had for a long time, a lot of excitement around AI, but jury's still out. We still need to kind of deliver more of that. And we'll see many more things over the next few days of how that works. But I thought getting both Tammy and Kim's perspectives on what they've done, how they've seen it, what's worked, would be an incredible way to sort of ground us in what's worked well. We'll maybe start by giving a little background on each of your systems. Maybe Tammy, if you're okay with introducing the audience to University of Arkansas to start with, that'd be great.
For sure. From the Little Rock, Arkansas, University of Arkansas for Medical Sciences. We're the only academic medical center in the state, level 1 trauma, solid organ transplant. We kind of take care of the sickest of sick. And we serve a really important purpose in educating our clinicians, lots of different colleges. So we have those challenges of an academic medical center and supporting the education and research mission with the clinical engine. So we have worked a lot to try to maximize what we can offer and support. And with all the things you said earlier about eroding margins and challenges, we definitely are the kind of the key group in our state that's trying to meet a lot of needs. But I think it was in the brochure, I'm the Chief Nursing Officer, but also the Associate Vice Chancellor for Patient Care Services, Clinical Operations, so kind of a hybrid role. I have perioperative services, interventional imaging, lots and lots of the clinical operations. So got my hand in a little bit of everything.
Thank you. Kim, if you could share a little bit both of your background and a bit of Honor Health as well.
Well, it's no coincidence that we're both nurses, and we're both labor and delivery nurses, too. We found that out last night. So if you thought working with nurses was awesome, it's more awesome with an OB nurse.
And we can't talk about the full moon.
Right, and the full moon comment is real. The issue is real. So a little bit about Honor Health. We are in the greater Phoenix area. We're the product of a merger between Scottsdale Healthcare and John C. Lincoln Health Network many, many moons ago, right around the time I decided to understand Qventus a little bit more and become a system. We have just recently purchased the Stewart assets that were in town. Everybody knows about Stewart. I hate to even say the name Stewart, but we have those, and they're hooked onto the Honor Health chassis. So we have now really 8 big acute care hospitals, a micro hospital, and then several thousand team members now. And we have grown considerably. We have 3 level 1 trauma centers. We have a pretty big academic affairs, and we have 5 of the 10 recognized magnet hospitals in the state of Arizona. So we're deeply connected as a system, and we try to, through a process, to manage costs and efficiency, things like that. We really operate as a system. We try not to do everything at every site, and we try to leverage ourselves as a system of care so that we can manage expenses, but it's also to manage the people, right? To get the right talent. So it's been, I think, advantageous for us from a patient experience perspective too. So we move a lot of patients throughout our network to make sure they can get to the right care. But I think that merger was when I started to learn a little bit more about what Qventus could offer. And I remember the first time I met somebody, I'm like, I don't even understand how that works. And it was probably the third meeting I had with him. I'm like, okay, So what you're saying is that like this is like an engine, right? It's going to help us move patients through the system of care more efficiently, and it's going to help use human science, right? That human science piece I think is important to help people really do the right thing. And so it took me a little bit to get, but I was an early adopter, and it was hard to sell to people in the very beginning. And as an organization, I remember having several meetings about actually moving forward and people being a little bit leery of what it could do or the ROI on that. So it turned out very well. And we have several of the engine in place.
Well, we definitely need to do a better job of simplifying our story.
Yeah.
That is a good lesson. But I think maybe on Kim, on that point, I think often this kind of major change or deployment of new technology comes with a vision. What was sort of that vision for you around system-wide transformation, and how did you think of scaling across the system versus one-offs? And
well, after we merged, it was very evident that we had at the time 5 hospitals that did everything they wanted to do and the way they wanted to do it, and none of them were making length of stay. It was very inefficient. It was hard to share staff. We have a very large float pool because we have 0 nurse travelers, we actually had about 500 during COVID, and within 6 months we had 0. So we built a very strong platform, but you can't do that unless you really standardize how you care for patients and how they move through the system. And so my goal was to start to centralize some things and then be able to, no matter where we move a patient to or how we have to approach care, that it's very standardized throughout the system, and we optimize using Epic. And there was a lot of opportunity there that we hadn't unlocked, and we didn't want to duplicate things. We wanted to really partner to try to make things better and to use what we had or adjunct to that so that we could get better throughput. I think the other thing is during COVID, we launched this, not a great time, right? And to your explanation, really 6 months after we launched the first site, which was our hardest, most inefficient site, we got hit with COVID. And so I don't recommend that. Don't have another pandemic. But we learned a lot from that process. And I think one of the things that came out, one of the good things that came out during COVID was really we have to act as a system. We can't go to the table and have try to manage it as a state and try to optimize each site in their own little way. It just doesn't work. So we had centralized staffing, centralized patient placement, centralized transfer center, all these things that I thought everybody was doing, but it's hard, and so not everybody does it. But we needed to be able to do that, and in order to do that, standardizing that throughput was really important. So I think the vision was to make a great place to work, right? So our people liked it. What we were offering made their jobs easier, that we could not be short on beds every day, right? And get the length of stay down, because patients don't necessarily want to linger and stay longer than they need to. And we really wanted to standardize those processes. So I think that was the biggest driver, becoming a lot more efficient. And I have to say, part of my career, I've had many jobs, but one of the hardest jobs I ever had was being a supervisor, right? And I remember having that conversation, and I said, when you're a supervisor at the front line and something happens, you see it happen, and then you're scrambling around and you got about 5 things in your head, and you're gonna try all 5. But if somebody could tell you, try number 5, you don't even have to do the first 4, it's gonna work the best, that was really appealing to me. So I thought really providing something for the front line to manage what sometimes they can't manage would be a real plus for them, really. And the time that they can save, they can spend more time with patients.
That makes a lot of sense. Time maybe similarly, I think you're pretty foundational to some of our surgical work from the get-go. What was your vision of transformation across the system, and how did you think of it?
Well, I mean, obviously with our perioperative services, and for all of us, huge driver of our revenue, 50% or maybe more sometimes. And how do we maximize what our capacity is? We had great leadership in our perioperative space when I stepped in 2018, but things were manual. When you looked at our OR scheduling, how we were gonna help surgeons understand their utilization, were they being good stewards of their time, were they not? Nothing was automated, really and truly. So trying to figure out how to maximize, make things easier for our surgeons. And you know, what you said is so true, making the right thing, the easy thing, releasing block. It's the right thing, but is it easy?
Yeah.
You know, no, it was a phone call or, you know, whatever worked, or schedulers, you know, seeking them out. So, I mean, that was the driver. And obviously when we're looking at our priorities, strategic priorities, everybody's thinking about finance, but in this case, it's also meeting the needs of more patients in our state. So those two weren't in competition. But we benefited from early on working with Qventus. We were an innovation cohort before it was a thing, maybe. I have to have David fact check me on that. But so being able to leverage that, make the case, which is often not easy, was a little bit easier for us because we saw the ROI just through the development, and you know, then expanding out from that has been also not a hard case to make because we had that proven track record. But so it really is about what are the next steps? How do we continue to push? And you know, I'll use a Southern term, get the blood out of the turnip, because we're all trying for that. We're not going to arrive. So that's really what our vision was. And we didn't necessarily know where it was going to take us, which is kind of the fun part, as to where we are now.
Absolutely. And how did you both sort of go around selecting use cases, thinking about what you do within the existing systems or the existing EHR versus where to partner with someone else? Like, what was sort of your thinking process through those things?
I think impact, you know, and what you also hit on is really looking at the multiple ways that the use case can be affected, not just in margin potentially or efficiency, accuracy, but how do we get our clinicians at a place where they are doing what we need them to do? And they're working at the top of their license, their contribution to the clinical engine and patient care is really where it needs to be, because there's so much that we know bleeds into what they do that's tasky, administrative, checking boxes. You know, they talk about, nurses will talk about feeling tethered to, you know, the computer for their documentation, whether that's perceived or reality. But also it's that 10% of all other duties as assigned that can really, not only do you burn labor, you don't need to burn in intellectual capacity, but it's their engagement and their satisfaction with their job. So, you know, if we're trying to get the most out of our teams, you know, we really have to think about those use cases where we can see a big benefit and return on investment.
That makes sense.
I think the other thing too, like I use, I'll give you a good example. So we were working on the inpatient solution, and our next thing was mission control, sort of centralization, and using that. We had it all plotted out, we were going to do it. Then when we got to that, Epic had released, you know, mission control. And because you guys work so closely with Epic, and I'm assuming other EHRs, you were like, I don't know if we can do much better than that. And I appreciated that. And your money will be it'll be better spent if you do the peri-op solution, just get right to it. And so the team really worked. That, you know, when you're executing, your team is there. Our team is learning from your people more and more about what things can can be solved. And so I think that actually in and of itself then produces more ideas. Having those peri-op people really looking at deploying the peri-op solution then got people thinking about how could we use this in PATS and some other things. So I think the more we have, the more we're going to have. And I think to go deeply in a partnership so that our people are working together, that's going to give us the best thing. Nationally, there's a lot of, I don't know if it's somewhat negative about nursing unions. They don't want us to replace nurses with AI, right? And so they immediately go to that.
Right.
And it's not like that at all, right? It's allowing us to do better, more with what we have. And I think the more that people get exposed to it, they are going to be the ones that come with creative solutions. Frustratingly, the easy stuff is, in my mind, things that don't touch patients, right? But the most success we've had is with the ones that do.
Right.
Because I think it's our staff, our clinicians who are touching patients want to do more, they want to do better. And so I think that's going to be sort of the fuel. We do need to go deeper on this. I mean, I don't know if anybody doesn't have any of those problems about, our margins are getting skinnier and costs are getting out of control. I don't know if you don't have all those problems, if that video wasn't made of your site, then we definitely need to talk. But everybody I talk to is having the same problems. And so we're trying to look at how do we deploy more impactful AI solutions that will make a difference in cost and salaries, in lots of things. But unfortunately, salaries is one of the biggest things that we have to deal with, but also it's trying to find the right people too, right? So I think we have to start really pinpointing some easier things that are in rev cycle and things like that. Rev cycle comes to mind because I'm always picking on them because they're like, oh, we can't do that. I'm like, if we can do this with patients,
yes, you can.
I feel like you can do it on pre-auth and some of these other things. So they're starting to do that and starting to be a little bit more open-minded, but everybody is really afraid that it's going to replace all their staff and all that. And you can't keep up with a lot of those areas with turnover, especially the entry-level stuff. Your slide up there that talked about, like our call centers, big numbers of people to try to manage all that. And what we found even and I'm not going to give it away, my team's going to talk about the PAT solution, the preoperative solution, but when you are able to develop and learn with the team, they're the ones that are going to solve some of this and not be so afraid of it. And I think we changed the look of this over time because we're going to be doing more of the work.
And I think that's actually been one of the funnest things is to get that pull from them. There's nothing more rewarding for us, and there's nothing more. When you get those two minds sort of working together, there's nothing better than come out of that.
That is exactly what I've experienced with our Qventus partners. I often describe them as their sponges, and they jokingly talk about when Tammy fusses, they listen, because they know if I'm complaining about it or frustrated by it, so are others. And a lot of times that's where the use cases come from. It's just that interaction, that free flow of information, and just some really smart people.
Almost all of our good ideas have come from interactions like these, where feedback or something sort of leads to a whole new area. It's sort of one thing to have a vision, but as you go into it, there's both challenges in implementing and integrating and driving the change. You talked about staff fears. Maybe share a little of like what does that look like, and then we'll go a little bit into the results you've seen from that as well.
Well, I think that it's just, we all get it. It's logical. That's where the mind goes to, where our team members think, well, this is all about saving money or cutting positions. And I think the key to dispelling that, or at least minimizing it somewhat, is transparency and really talking about what the intent is, because while there's always the trying to conserve scarce resources. It really is what this kind of work and the platform can offer is efficiency, accuracy, again, getting them back to the work that they really want to do. And, how do we maximize the human resources that we have and help them, be more efficient? So it's, to me, I have just found, like with, you talk about PAT and, our nurses that are involved in that, is involving them. They are at the table as we've worked on this. They've seen what the goals are, what we're trying to achieve, and it's not about cutting positions. For us, we knew that growth was coming and we needed to be prepared, and what we didn't want to do was add FTEs. So we'll talk more about that later, but it's just involving them and understanding what can be yielded for them to help and to help our patients.
That makes sense.
I think the transparency about the data, one of the biggest things when we started to do some, publication of a dashboard and track days saved, money saved, and creation of beds, OR time, when that was a big eye opener for people, right? We've added basically block release, 13 hours per OR in our system, block release per month. That's a lot of OR time, and we've been able to grow the surgical cases, the surgical volume with the current footprint, right? So once you start to make that very transparent and share that, it seems to help with some of that. The other thing is, I'm looking at Harold right here. Harold is the Qventus whisperer.
Yeah.
He is a genius in really in that whole process improvement science, and has been a great translator for people, for both coming from the health system to Qventus, but also the other way, and helping people understand the capabilities, and if it's not perfect, what we can do to make it that way. And so having somebody embedded in this, Harold's partner is one of our sort of retired CNOs who was strong-minded. She was at our hardest campus to get people to kind of move to different thinking. So it was those two that kind of led that effort. And so I think having those key people. I went to mHealth Fairview. I went to a meeting up there, and I met some leaders up there, and they said, don't underestimate the process improvement part of this and what you need to have to continue to drive the change. And so I think I have amazing leaders, and Harold has been a gift, and working with the team, I think he has won the hearts and minds of everybody from both partners. And so I think having somebody that has that expert
Absolutely.
look is really important. It makes it easier. I will say that doesn't, we again standardize, roll this out each campus, and then you deploy, and then you go back and you're like, okay, we decided we could do it better. And so here at this site, we're going to put our own spin on it, right? So, and it's a certain amount of that is okay, as less foundationally it's the same. So we still have that. People say all the time, isn't it easier if you just hire all the physicians? No, slightly more expensive, but the staff has to have some, they need to personalize in some way.
So what for them?
Yeah, it's a little bit, but foundationally it has to be the same, and that's really key for having Harold. And I also think, the data really does spell a story out, especially when you look at the OR times and the ability to add actual robot time. We have all these robots, they're hugely expensive. We've been able really to optimize that and to show that to our surgeons who have their own agenda, right? I mean, they want
Yeah.
more volume. They need the OR time, not only just OR time, the OR time that they want at the
Yeah.
time that they want it. And so I think making that transparency has been a real game changer in the peri-op area. I would even venture to say, I'm looking at Noelle here, who's our VP of Peri-Op Services, we got so efficient, we almost went too far. And it's really hard to get add-ons. You used to have enough inefficiency, you could squeeze things in throughout the day. And we got so efficient, we kind of took it to a different level. And so it's been a little bit, we've had to like lean back and figure out how we can get add-ons, especially in our trauma centers. But it's almost laughable, right? We're too efficient in the OR. Anesthesia doesn't have they go from boom, 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 right? They're stacked. There's no hour to go put your feet up. Like it's efficient. And showing them that data is powerful. So I think having a scorecard and really understanding that has been a key driver.
And I think you already started touching on the results. Maybe I'll have you share maybe some of the different results across, since you can get a chance to see it across inpatient, across peri-op, across PAT.
Yeah.
Maybe if you can pull that up and maybe if you can share some of those, that'd be great.
Yeah, this slide, I love this slide. Actually, I'm going to put this in my board packet. Because if you look at year over year, we're still creating beds. That's what's powerful to this. And we're only saving money if you can fill the bed. Well, we've been lucky enough to be in a very growing market, and we're filling the beds. So basically, this is the inpatient solution, and all of our hospitals, I've been doing this for 40 years, right? Ish. And every single one of them are below 1 on the ODE length of stay. That has never happened in fact, I tell people that and they're like, not really. 1 bounces a little bit. We've got to keep, focusing on that. But they're all hitting the metric, all the big acute centers. We have not deployed to the new assets that we purchased from Stewart, but we're getting ready to do that. And they have a lot of room on length of stay for sure. So that's I always say there's not 30 million, a stack of $30 million behind my desk, but we have capacity and we're growing. And year over year, we're growing in double digits. So it's been very, very good. And then I think she has the...
Go to the next one, yeah, I think.
Yeah. The OR capacity.
Jamie, could you go to the next?
Do you have the next slide? This one everybody gets romanced by, right? And it's true. First, when they showed me this slide, I'm like, man, that's one of those, finance is never going to buy it slides, but it's true. And I am shocked by this because, first off, it's inefficient, right? Because people call and they want to schedule something for 2 hours when the last 10 times they did it, it took them, 45 minutes. So really being able to show that and I think optimize those schedules, we've really been able to create some capacity all across over 100 ORs now. And so we definitely have grown. In 2025, it looks like it's going to be that much. And it definitely has paid for itself. And the physicians love it. And if you've ever worked, well, you all work in a hospital. Like how many times do you get to a medical staff meeting and one of the hardest surgeons to manage says, I can't believe how much better this is. Thank you for doing that. Like it's a little bit shocking. And they understand the efficiency. That's all they've really wanted. And they really have bought into this. A couple of them know that we have it in, I call them the OG hospitals, the originals. And so in the new hospitals, like, when are we going to get it? How long is it going to take? What's going to happen? So they're anticipating and excited about it as well. I would say this one, the surgical growth piece, because they themselves get immediate love, it's probably easier than the inpatient one with the hospitalists and really changing behavior there. And we have several different groups at each site that that was a little harder sell, and it's taken a lot longer to really hardwire that. But definitely in our hospitalist contract, They know exactly what they have to do with that and what their part is in the throughput piece, and to use the Qventus data to be able to do that, and then the process around the multidisciplinary rounds. And so we built that into their contracts. So that's if we change, or if there are new people onboarded, that's one of the first things they learn about, because it's important for them financially to be able to do that. Yeah, we've kind of weaved all that together.
And that's actually a good point of like back to what I was saying. Like it's oftentimes not just the machine learning, not just the technology, but like all the organizational pieces you have to bring around together as well.
Yeah, sure. The change management piece, not only in your staff, but the physicians is big. And it's probably one of the biggest barriers, really, to being successful long term. And the other thing I talk about is perseverance, right? So the minute that you start any change, there's a subset of people that are like, well, it didn't work. That they told us we were going to have 40 deliveries and it didn't happen, right? One day. And so you can't, the perseverance is really important to drive through that, listen to the problems, which sometimes there are, sometimes it's just understanding it, right? And so we really, I think, again, I give credit to Harold on this, understanding both perspectives, making the change, and then driving forward. It's an iterative process. It's never perfect first round. And I think that you just can't give up. You can't, as they say, throw the baby out with the bathwater, right?
Totally.
Yeah.
Tammy, you want to share?
Well, I think there's a lot of really important things you hit on there. But for us, we've had great outcomes, obviously, with Qventus. We're smaller, don't have multiple hospitals and that many ORs, but from an ROI standpoint, it's really about 5 times. We're on track for this to be our best year, and we've been at this almost 5, I guess, with Qventus. But one of the things that I think has really helped us with adoption is that we've really just embedded it as this is how we do us. This is how you do business as a surgeon here, how you access time, how we kind of track your stewardship and your block utilization. And that has really helped with the engagement. We still have room, lots of room, but the information that you guys share with us really makes that so what easy to share. I was sitting here thinking we can do a much better job, and I want to kind of get with what I would call our non-engaged, not utilizing it the way that they really should, because if you look at our data from 2024 to where we are with 2025, our engaged surgeons are growing at 19%. Versus the non-engaged. So that I just got that information recently, and we need to leverage that and say, it's not about doing the bare minimum. You really need to be working with the system, releasing, and when, it's so easy for them to push a button, and when they get a nudge that says, okay, the likelihood of you using this time is extremely low. If you release it, here's what that'll do for your block utilization. And using that information to, for lack of a better word, enforce your rules for block and scheduling, has helped us a lot. And we're transparent with our scorecards.
Yeah.
I'm famous for a quote. I think they're going to put it on my tombstone. And somebody just told me this. I said this a long time ago when I was running one of our hospitals. You can choose not to do it. You just can't choose not to do it here, right? And so that's the sort of the stance that you have to take at some point.
That is what it takes. Yeah, for sure.
I might print shirts or something.
Use that.
Yeah, you can choose not to do it. You just can't choose not to do it here.
Yeah, we should get you a shirt with that. And then, Tammy, I think you've also been an early adopter on the PAT side as well. I'd love to share some of the results there.
For sure. We're, I guess, about a year in, but already seeing some great outcomes related to that. From a productivity standpoint, our screenings per hour have gone up 50%, so everybody loves to hear that. Definitely getting good feedback from our teams about, oh wow, and they're starting to feel it, and that goes back to value-laden work as opposed to what maybe they perceive as not. Cancellations, already seeing 25% reduction in cancellations just with the PAT work, and really kind of closing some of those loops. And manual processes like faxing.
Yeah.
Reduce the time associated with that by 60%. So when you start adding those up, maybe the 3 minutes shaved off here and, one additional screening per hour, but what we've seen is all of that combined is really making a difference and gonna open up not only capacity and hopefully our ability to do a better job of optimizing, but it's just laying the groundwork for efficiency, accuracy, and being smart about our FTE resources. In this space, we have mid-level providers, mining charts, and what we're seeing and the functionality and the deliverables for maximizing that process is really compelling.
Yeah.
And I can only imagine where we'll be in 6 months.
I know the rate of progression here has been pretty incredible to see as well. Yeah. I know as you shared about like some of the staff benefit, but I think Kim, you were referring to this as well. Sometimes staff can be a little antsy about sort of feeling that perhaps this is an opportunity.
Yeah, it's funny because, so the PATS thing, it's the perfect scenario, right? That bubbled up from the bottom and it was supported by the top. And so we were doing budgets. We never went in and said, we're cutting because you're using this now. We never did that. So actually, Noel, we were doing some budgets for PATS, and we were going through some volume stuff for the administrators of each of the sites. And they have a productivity metric, right? And so the number of patients that they're touching has been going up because they're not only, they're now even doing some work in the procedural space too. So not only are we're touching and understanding every single patient schedule for surgery, but they're getting into the procedural areas as well. So we were doing the productivity, and I'm like, okay, so basically you should have 10 FTEs more than you have right now to do the volume that you're doing. It just happened. And I hadn't even really noticed. Actually, I think both of us were kind of like, wow. So that's people, they weren't there. We didn't get rid of them. They've just been able to touch more patients and become a lot more better productivity. And so when we sat down and looked at their year to date, I'm like, holy cow, they should have 10 more FTEs and they don't. And so those are RNs. Those are, a little more expensive. And then I would say the other piece, besides all this ROI stuff, is the ability to cull the chart and to understand any risk that patient may have that a human might actually miss. Is incredible for patient quality. And so I think they've been able to touch more, feel better about what they're doing, what they're touching. And I think from a quality perspective, we're picking up more risk than we probably were before too.
We're feeling the same thing. And similarly, it wasn't about cutting positions, but it was about not adding. Yeah. Because we have experienced growth and we're putting through more cases because we, anywhere anesthesia is occurring, we're doing that. So, we really should have been at a place where we needed to bring more nurses in, and we haven't. Yeah.
I think that's one of the things we've seen in that use case as well, as you were saying, there's more things that often get missed when the staff don't have time. So it's kind of a win-win-win of the patients better prepped for surgery, more of their gaps of malnutrition and others are filled, and the staff's feeling better. That's sort of the win-win-win that you want to look for in that. These results are really compelling. As you think of sort of the future, before we'll open for audience questions in a second as well, how do you think of the long-term vision of AI applied into your health system? Like, what's the one thing you wish people understood of what's possible, or what is it something that you are excited about seeing out of AI for your health systems?
I think you should move your corporate office in with us, that would be first.
I will say that with the amount of time the team spends there, we might be actually
You might
big cost
actually
savings
save some money there. It
there.
might make you more efficient, right?
Yeah, exactly.
Like, ideally, you know, you guys are able to attract a different level of talent to do this work. Because when we first started, it was the question of, should we do it ourselves? I'm like, we can't even get an Epic upgrade going here, people. I don't think that we're going to have the people to do it. We don't have the talent to do it. And I mean, that's not a blow to our team. We have a great team, but they don't have the ability to do that. We need to have boots on the ground. We need to integrate and mix your great minds with ours. And I go back to that example with PATS and what we've been able to accomplish because the teams are together. So I think our goal is that we do want to do that. We want to embed some talent with our team to expedite ideas and to solve some problems. And we have an innovation center. Like we have the ability to test some things, I think, before it goes live. And I think that's a critically important piece. I think a little bit more personalized to your own problems, which I think you guys pride yourself on. You're helping us solve our problems. And I think in order to do that, I think long term we need that talent. I also think something simple, please don't ask me anything about this electronics of our phone system, but you have to have, your infrastructure has to have the capacity to handle all this. And so as we get going, we learn, oops, that may not be able, we might have to beef that up or whatever. And I think if we embed the talent, I think we can get ahead of that a little bit better, especially if we can continue to do that. I think that we have some technology. We have an Artisite platform that we're testing now at one of our sites. Like, I would love to see, because if you're there and you see it, you could see some opportunity that could make that even better around patient safety and sort of the virtual care piece of it. So I think the future is much more integrated relationship or partnership. The other thing, and you deal with, in a health system, all these vendors and all these people who always want something, and this is very much like a partnership and less of a business deal. And I always tell people, I don't suck up. And so I'm a huge fan because of that. It's more of a partnership in helping us solve these problems. And if we could make that just come alive a little bit at the sites, I think we'll solve a lot more problems. And then you'll be exposed to things that we have that maybe you didn't know about. Every piece of medical equipment you buy now, they tout has something in it that does AI. I don't think we've even unleashed any of that, to be honest with you. I think it's probably part of the sales pitch, but I feel like if we had true experts embedded among us, we would be able to optimize more. And it would be much more personalized to the reality of what we have.
I think even more so than, as I said before, like the operationalization of the AI is so important, and being intimate to the problem and the work being done, which is why I think with you, we are exploring this model of embedding people to take this AI solution factory to that next level. It's very critical, because that's the way you actually operationalize the AI versus just having something that sort of sounds good but doesn't actually go to the work.
Yeah.
And I think the long-term vision we probably all have, and Dr. Joseph Sanford's our CIO, he's here in the audience, and we were chit-chatting yesterday. It was, synergistic opportunities, because there's so many different platforms out there to address all the different nuances of the healthcare industry and engine. So in terms of excitement, what you presented this morning, is really exciting.
Thank you.
Because that feels like it's going to help us with the synergy and avoiding one-offs and silos, which is so hard. And it is our inclination, and it's just like natural to healthcare. That's what we do. Everybody's got to have their thing, their special, and that bleeds all the way down into just different types of units. And from a 50,000-foot view, it's looking at, but where is everything connecting?
Right.
And how are we making sure that we don't have silly redundancy or conflicting? Because there's stranger things have happened in healthcare when we go about it that way with the lack of kind of the big picture. Is how does this all work together from rev cycle to scheduling an MRI?
Yeah.
So.
I think the other thing, and I don't, we just recently, it was announced because we didn't have enough to do, we are now the clinical affiliate for the new School of Medicine at ASU. And it's a different program, kind of focused on innovation. You'll come out with an MD and also be a medical engineering graduate. And so I think as we look at embedding or doing something deeper in partnership, creating a way to create the talent that we need would be really important. I want 10 of Jeff, right? I want.
I would love that too. Yeah.
I know.
Yeah, we need to figure out how to clone him.
His office can be right next to mine.
Yeah.
But if you had a way to partner to create the talent that everybody needs, because I think there is in health systems, in the IT department, right? We have hundreds. I remember growing up in a leadership position and going through a budget time, and I remember the IT guy asked for 40. He had 40 people, and I'm like, 40 people? Good Lord, I could run a whole nursing unit with 40 people. Why do we need 40 people? We didn't even have Epic at that time. We have hundreds of people in our IT now, but yet we still, and they can't keep up, right? Yeah. But we may not really have the talent to be able to do this work, and so I think that's also an opportunity for us.
And I think what we actually find, if you look at the engineering world out there, where there are people who want to make an impact, like many of them get pulled into like optimizing clicks and ads and this and that, but they actually, when they come work in healthcare, they feel the real impact of what they're doing. So I think we have an opportunity as an industry to attract more of that talent into that as well. I've enjoyed I keep enjoying the conversation enough that I forgot to open it to the audience. So why don't we make sure if people have questions, they can ask as well. Any questions among the audience? Yeah, Jason, kick us off.
Kim, I think I shared. Thanks. Kim, I think I shared with Harold, but maybe not with you, that my mom was hospitalized last year. She lives in Cave Creek, so she was hospitalized on her. And I was visiting her, and it's obviously one thing to design a solution, another to actually have your family member experiencing that. So she got great care, got her echo, got discharged on time. As we've evolved the platform, obviously we're moving from technology that impacts providers, that impacts operators, to now touching patients, particularly with PAT. I'm curious for both of you, Tammy, as well. Now that you see AI starting to touch those patients, how are you handling the change management with your patient population, right? Because it's one thing to try to get providers to do the right thing, and maybe the answer is patients are easier than providers. That I'm willing to accept that answer, but I'm curious, like, how are you perceiving that challenge, and what are you doing?
Well, I think patients want everybody to be on the same page. I think that makes them feel safer, right? When you ask them the same question 74 times, they think, well, what the heck happened to it? Why did they have to know that again? Didn't they tell? Didn't they share? I think those kinds of things give patients a lot of confidence about safety. I would say we work a lot on the patient experience. It's a foundation to kind of who we are, quality and patient experience, and all of our sites, even our trauma centers. Our trauma centers, after we merged, they were like at the 25th percentile. It's tough in a trauma center, right? All of our sites, a couple are in the 90th percentile for likelihood to recommend, and all of our sites, I'd say all the trauma centers, probably 65th percentile in that question, right? So you want, plus the docs are happy, so they're telling the patients they're going to the best place, right? So I think our patients have never been happier. And I think it's multiple things. But if you really boil down, we just had Dr. Lee came in from Press Ganey and talked about what's important to patients around patient safety and, social capital to your patients and how you treat them and personalized care. And I think being able to do this and being able to inform a patient what's going to happen next, getting them out on time, and everybody being on the same page, and I think that sends a big message. And I don't think that we'd like to survey our patients that interact with the PATS bot. We haven't figured out how we can do that yet, but we want to get more feedback. We get the general feedback from patients about the experience, and I think the efficiency has come across in some comments on the peri-op piece, but I think they appreciate that, kind of everybody being on the same page. One thing I think really makes people think we don't know what's going on, and we're all guilty of this, is how many times we ask the same question. And think about if you're a patient, like I'm allergic to sulfa, right? And about the 10th time you go in and somebody asks you that, you're like, okay, everybody knows I'm allergic to sulfa, right? And I kind of almost had a little anaphylaxis from it last time that I had it as an adult. And so I don't want you to mess that up, right? So if you get asked that 10 times, you're starting to think nobody knows it. And so I think that piece is really critical in from a patient's perspective. But
Patient preparation for this
Yeah,
technology and interacting with the bot is an area, at least in my opinion, that we really need to work on and evolve. I mean, for us, kind of the obvious was to make sure our clinics were prepared, and when they're having those appointments, the surgeons as well as the clinic staff could communicate and let patients know this is, how you're going to be contacted and screened and so on and so forth. So on that end, also leveraging your patient family centered care advisory or whatever your structure is to get feedback on how it feels, how it works, and that kind of thing. But to your point, we're really to a place where I want to do some surveys and get that feedback. And I know you guys want it as well.
Yeah.
Because that's really where you're going to continue to hone and make it a more natural experience. It's pretty natural and a little bit scary.
oh yeah,
almost.
it is a little bit
But
scary.
for the most part, I think that that's how we're preparing is on the clinic side. But we can do better.
I think that's a great, we just had we've had a patient advisory council for 20 years.
Right.
And we just had their birthday this week. And we did ask them that. And that whole, like, don't ask me the same thing 20 times makes me think you don't know what's going on. That's alive and well in that. The efficiency piece of what your physician tells you is going to happen actually does. And everybody being on the same page is pretty powerful. Now, we're not perfect in that, but I think this enables us to get better and better at that. But they didn't really mind the whole bot thing.
Right.
They were like, as long as you get the information and you don't ask me that 20 times,
Right.
Yeah.
I'm all over it.
As long as it flows.
Yeah, that's a good process to go through.
Do we have time for one more? Yeah, go ahead.
I just wanted to ask, your surgeons, are they employed in your system? Or are they independent surgeons?
Most are not.
Most are
employed.
independent.
Most are not employed. Some are. I don't know the percent of the whole, but
Okay.
it's not that many. But some of them are on a PSA, not employed, but PSA, but most of them are independently aligned.
Great. And the reason I ask is because you brought up a very interesting point is what level of efficiency is optimum efficiency? Because you can certainly get, the efficiency is a trade-off. And it's a trade-off between what the system considers efficient, what the anesthesiologist considers efficient, what the surgeon considers efficient.
Yeah, and those are all three different ideas.
Yeah. And so I'm wondering, in your dashboard, what you use, first of all, to convince yourself that you're maximally efficient or optimally efficient, and what balancing metrics do you use to make sure that you're not achieving that at the expense of your surgeons?
I don't think the surgeons would say that, but anesthesia might, right? And if you could create a virtual anesthesiologist, we'd all sign up for that. Because
We got
that's our
some
biggest
time before
barrier.
that happened, but yes.
That's a whole nother topic. It's a great question. What's the balancing metric? I think the balancing metric is going to be like add-ons and how we get those done in a timely way, right? Because again, we're so efficient in this sort of stacking, it's hard to do that. But part of that is sort of electrified by anesthesia issues.
It's interesting you say that, because in efficiency, anesthesia is your biggest ally, because efficiency drives their business model.
Right.
So in efficiency, I'm an anesthesiologist, and I've been in the practice for 35 years.
We got some openings.
Okay, and the first 10 or 15 years of my practice, OR operations were centered around surgeons, because growth was our objective.
Totally.
Okay, now if you survey CEOs in terms of strategic objective, many of them are looking at reducing cost of production as their number one. In that, efficiency becomes really important, and your anesthesiologists are your biggest allies in trying to create OR efficiency. The problem is getting the surgeons to agree not to ask for 3 rooms for the 2 cases and what have you, multiple rooming and all these practices that drive up cost. So you measure, what fraction of the time the OR is occupied with cases. That's your OR occupancy. That's a good measure of but you also measure the fraction of the time a surgeon arrives in your facility but leaves, and what fraction of that time are they sitting around twiddling their thumbs, not working. That's the balancing metric from their perspective. And that might lead you to where optimum efficiency.
Yeah, we the most, so all of we've grown, right? So we've grown a lot of volume. And if you look at the majority of the surgeons who do the majority of their cases at Honor Health, they've all grown too. So anesthesia has grown. They have been constricting us from growing, and we're working on that. But I think if you were to ask our surgeons, they would like to see that, right? They like to see that they're growing and that we're healthy and we're growing. Anesthesia does not want, like it used to be, you're totally right, like you would have a 7, 8, 9, and then a noon. And then a 2 and a 3, and then, So we don't do that anymore. We're stacking those. Or you schedule a 1-hour case for 2 hours. That was, famous for that, because then they could stick something in there. We kind of stopped doing that. So because we've gotten so efficient in the stacking, I'd say anesthesia is much happier because they do not have the people to do that, but it's driving the surgeons a little bit differently. Now, they're growing, so I think that's the balancing metric, right? They're happy because they're growing and they're getting more cases, but there's not a lot of sitting around waiting for things to happen. Mm-hmm. And there's not a lot of dead time in the schedule, which definitely traditionally was that way. Part of this has allowed who has too many anesthesiologists? Anybody? That's the other person I want to meet. Okay, see, there's nobody that has too many anesthesiologists, right? So, and our team, I'd say that's the number one pain point every single day, is making sure we have enough anesthesiologists to staff all of our rooms. So the efficiency piece has helped us manage through that. We're probably in the best shape in the valley as it relates to anesthesia coverage. It's a daily issue. And so I think that the efficiency has really helped that. We wouldn't have made it had we not become so efficient. We would not be able to do what we're doing right now had we not done that. But on the balancing piece, right now they're growing, so they're happy, but there is no dead time in there. So the surgeons come and they're hitting it. And if they get an add-on because they were on call the night before, that's the biggest pain point, is that we might have to add it on to the back end. They can't squeeze it in. Sometimes they can, but it's a challenge. The add-ons, especially in the trauma centers, has been a real.
And you have to find the ties that bind.
Yeah.
I mean, the balancing metrics are one thing, but what are we all working towards?
Yeah.
Whether it's the circulator, the scrub tech, whomever it is. But I can definitely tell you that I'll have anesthesiologists say, well, Tammy, are we looking, at TOTS time, to cut? I mean, I'm done. I'm turned over to the surgeon. How long is it taking to position, do this, do that? and out of OR and things like that, where
Wheels in, wheels out.
yeah, but there are these pieces between wheels in, wheels out that anesthesia affects clearly that we can measure and highlight their efficiency, as well as the surgeon component and so on and so forth. So, I think it's just pulling it all together and showing that it takes the entire team to ultimately achieve the goals, which are many.
Any other questions?
I can't see.
Okay, go ahead.
Wondering how this has impacted your inpatient capacity as you're more efficient.
I didn't hear all of that.
Okay, no, that's okay.
Inpatient capacity.
Yes, I'm wondering, as your ORs have become so much more efficient, how has that impacted your inpatient capacity? I know we're often seeing our EDs and PACUs compete for the same beds, and so I'm wondering how you manage that.
Well, I think that we're much more efficient getting patients out on time, right? So we even have a drive to get patients out before noon, right? And it's a metric we track with our hospitalists. So we're able to do that. I think I don't measure holds, and we don't measure holds in the ORs, but it's way better than it used to be for the right bed at certain. We have one campus, our Deer Valley campus, that is just packed, and we're getting ready to. We're building almost a whole hospital in front of it, basically connecting it to the current hospital. So we got a lot of beds coming on board. It's always way over capacity, but they probably have still some issues. But I think because we're so much more efficient getting patients out on time, that we have less of the holds. But we're pretty, even now, like I looked at capacity this morning, and it's hot in Arizona right now, so some people haven't come back yet. So we're running like 80% full. A couple of our hospitals more than 90%. The one I just said, Deer Valley, they're always at 100%. Like if they get below 100%, we're all like having a day. But for the most part, they're pretty full, and our throughput's pretty good. And I think the inpatient, it's about that, pre-planning and expectation setting that we do with the patients. And then they do measure, I think it's before noon, I'm looking at, how many patients get discharged before noon. So we get a dashboard every morning. It'll tell you how many people are sitting there with an order to go, leave, and it'll tell you also the number of patients that we predict will be ready to go today. So you can start to kind of line that up with, they do that with their OR schedule and number of patients to place. About half of our patients half of our patients are outpatient, right? So they may stay in an observational status overnight, but a lot of them go home even inside the hospital, right? Even the main OR does outpatients. Sometimes I have to say that 49 times to our board, because they think if it's an outpatient, then it goes to an ASC. Mm-hmm. No. So, and that'll be more and more, right? Even when you look at this inpatient list going away, it'll be more and more patients that are some sort of observation. But I think we're pretty good at moving through because we have the beds. But we still stay pretty full.
Yeah, we've stressed our system.
Yeah.
We're at ICU max, med-surg max more often than not, honestly. And we do measure OR recovery minutes, and we track that, and we have a threshold that we try to stay under, which is 250 minutes a month. So, I think that as we've gotten busier, because it's waxed and waned, whether it's pandemic, and then we opened another couple of surgical sites and are trying to backfill the main and all of that. But as we get back in and really hitting our stride on max utilization, it forces on the inpatient side all those things. We have all those things. The dashboards, we know in the morning exactly how many EDDs, we know how many surgical admits, we know how many we're boarding in the ED, and that concentrated focus. So is there a downstream effect? Yes. But from my standpoint, it's positive because it's forcing us to do things on the inpatient side that otherwise, maybe we sit back a little bit. But when there's a demand and there are patients boarding in the ED, we're potentially backing up the ORs, it's all hands on deck and everybody's paying attention.
That, if you're thinking about doing this, if you haven't done it yet, I highly recommend doing the inpatient thing first, because no matter how efficient you get in those other areas, if you got no place to put them, then that's a problem. And so I kind of learned that the hard way, right? We worked on the ED in the beginning, and you can fix all the ED problems you have if you just make sure you have inpatient beds, right? And so, I mean, there's always things to fix, but I think people get real attracted to the peri-op, and it's because it's a game changer, money-wise, big time ROI, that's easy to sell. But that inpatient piece, becoming efficient in that and creating those beds is key, in my mind. That has been great in that, you create the capacity that you need to operate. Yeah.
Let's see, you have time? No, okay.
Okay.
Misty, we'll connect you after with them, but thank you so much, Kim and Tammy, for sharing your story and sharing all the lessons.
Thanks.
Thank you so much.